In this video, we shall learn about the management of acute respiratory distress syndrome in children. This is a continuation of the last video that ARDS is diagnosed on the basis of Paley criteria, for which you need two investigations, chest X-ray and an ABG, and the ancillary investigations which may be done are complete blood counts, inflammatory markers like C-reactive protein, and appropriate sample cultures, and organ function tests like renal function tests and liver function tests. Now coming on to the actual management. Ventilation. The main part is of ventilation. Mild cases of ARDS may often be managed non-invasively. Moderate to severe cases, or those accompanied with hypotension or other forms of organ dysfunction, only these may require invasive ventilation. The main aim of ventilation is improving oxygenation while at the same time preventing further injury to the lung. Hence, the strategy used is termed as basic lung protective ventilation strategy. Another strategy is the open lung strategy, providing optimal PEEP to keep the lungs open and prevent their de-recruitment, that is, preventing them from not participating in oxygenation process. Optimal PEEP is one in which compliance of lung is fair due to alveolar recruitment with improving SpO2 and no hypotension attributable to PEEP itself. Remember, excess PEEP may cause overdistension of lung, causing decreased preload to the heart. Then there is another strategy referred to as the permissive hypercarbia strategy. In this, we accept high PCO2 around 60 to 70 millimeters of mercury provided the pH is more than 7.2, and we need to keep the tidal volumes low and low PC above PEEP, that is low PIPs, low pressures and low volumes, accepting higher PCO2s but to maintain a pH more than 7.2 to provide any kind of ventilator induced lung injury to the already damaged lung. Measures to increase oxygenation, which is basically calculated by the mean airway pressure, are FiO2, PEEP, PC above PEEP and TI. One must try not to exceed PEEP plateau more than 30 centimeters of water, because a PEEP plat more than 35 centimeters of water becomes an indication for taking the patient on extracorporeal membrane oxygenation support. Prone positioning may be tried as a transient recruitment maneuver. It improves oxygenation by recruiting the basal alveoli, but the effect gradually wanes off when the patient is turned back to supine. So this is slightly controversial, even though many intensivists find it useful. Next aspect is the hemodynamics. Remember, we do not want to underhydrate or overhydrate the lungs, because overhydration would worsen the lung injury by causing cardiogenic pulmonary edema in addition. Hence, fluid management in patients of ARDS has to be very judicious, providing just 100% maintenance, that is, the volume of drugs, infusions, blood products, and whatever is being transfused or infused should be subtracted from the total amount of fluid which is to be given to the baby. Once the patient is hemodynamically stable, his lungs are improving, and you are planning to wean, you may consider making the patient negative, that is, output more than input, to facilitate that the lungs become dry and extubation becomes easy. Then sedation and neuromuscular blocking agents ameliorate patient ventilator asynchrony, but they come with their share of side effects, including critical illness neuropathy and myopathy. Steroids given early in the course of management due to its anti-inflammatory action has been found to be of use in some studies, but the risk-benefit ratio again should be determined judiciously. Treatment of the underlying disorder is the most important step in managing patients of acute respiratory distress syndrome. Instituted early help in tiding off the critical phase early, along with supportive management, of course, and this facilitates faster recovery in these patients. Selective pulmonary vasodilators like inhaled nitric oxide and prostacyclins may be of benefit in patients who have a protracted course and in whom there is a possibility for development of pulmonary hypertension. Nutrition is a very important aspect in patients of ARDS. Patients must be started on nutrition as early as feasible to build up calories and promote faster recovery. ECMO is an extracorporeal life support system which does not involve endogenous functioning of patient's lungs. Indications are a PF ratio, that is PaO2 upon FiO2 ratio less than 80 in patients on high PEEP, that is up to 15 to 20 centimeters water for at least 6 hours in patients with potentially reversible respiratory failure. Remember, only those patients are put on to ECMO which have potentially reversible cause of respiratory failure. Oxygenation index more than 30, uncompensated hypercarbia with pH less than 7.15, and P plateau more than 35 to 45 centimeters of water. But remember, an absolute contraindication to ECMO is any condition precluding the use of anticoagulants. This is a very general and basic guideline of how to manage ARDS. It might not be as well explained as in the books, but the thing is that it gives a basic idea to the beginners so that they may now read on to the books and understand them. Thank you for a patient listening.